Good evening, students. Today we can see about the DPT and MMR vaccines in this class. First of all, we see the infections about the measles, mumps, and rubella, the viral infections. The importance of these infections are that if we know the complications and the mode of spread and all, we can know the importance of vaccine, because vaccine comes as a preventive strategy to prevent the spread among the non-vaccinated, and also to prevent the complication of these diseases if we are not getting the vaccinating the child. So the measles comes as a highly contagious disease because it spread even in by the mode of spread is mainly by the aerosols and suspended particles in the air, main the respiratory tract and conjunctiva. Even it can spread within in 1 hour if the infected person resides in that place, even after he left out the place. So such a dreadful infection that can easily spread even after 1 hour if that infected person is in that environment. The usual pathology is the viral particles. Viral particles causes the necrotic changes in the epithelium. The main route of spread is the colonization mainly occurs through the conjunctiva and the respiratory tract. So the necrotic changes are going to produce multiple manifestations which are basis for these clinical symptoms. First, the 4 stages of the measles infection are the incubation period, prodromal illness, exanthematous rashes, and the recovery period. The incubation period is usually 8 to 12 days. This period has high grade fever due to the primary viremia, and the virus particles goes to the lymph nodes. So the high grade fever occurs in this incubation period. In this phase, the child is not infective. Second phase comes the prodromal illness, nothing but the secondary viremia stage, where the virus from the lymph nodes spread to the bloodstream to the other organs. The Koplik spot, which is characteristic and pathognomonic of the measles, occurs in the incubation period, but usually we will miss this spot because it occurs 4 days prior to the rash. The rash is the clinical presentation which is pathognomonic for us to diagnose the measles infection. The typical rash occurs in the hairline, behind the ear, on upper neck, and torso up to the palms and soles. In the same pattern, it also heals or fades away with the desquamation as a point, with the desquamating skin lesions. The rash usually occurs on the 4th day, and the Koplik spots, which occurs in the oral cavity opposite to the premolars, upper premolars opposite. It's a whitish dot with a red base, characteristic feature. So any fever case comes to the OP, we have to examine the oral cavity. So this is the pathognomonic Koplik spots and typical rash which attract us to helps in the diagnosis of measles. The patient is usually infective during the prodromal illness and during the exanthematous rashes. So what we see in the OP or in the pediatric or in the clinical side, the patient comes at the stage of infectivity, that is prodromal illness. The rash, skin rash, and the mucosal Koplik spots in the oral cavity are all due to the small vessel vasculitis. This small vessel vasculitis attracts more leukocytes, which has the virus particles inside. These viral particles cause the edema and the further lymphocytic infiltration that causes skin rashes and nodes. The conjunctivitis and lower respiratory tract infection is predominantly due to the necrotic damage to the epithelium, thereby causing running nose, coryza, cough, and even pneumonia. All these symptoms. The giant cell infiltration that occurs with Warthin-Finkeldy giant cells is a pathological finding characteristic due to the intranuclear and intracytoplasmic inclusion cells, the viral particles within the intracytoplasmic and intranuclear region with more than 100 nuclei. These are nothing but the infected and fusion of the cells, epidermal cells, and even in the lymphocytic. So the infected cells usually has the multi-nucleated, often more than 100 nuclei, intracytoplasmic and intranuclear inclusion bodies, which are called the Warthin-Finkeldy giant cells. It's a pathological finding, but the measles is a clinical diagnosis only. We have to identify the child, and we have to admit the child and isolate the child, thereby preventing the spread of the infection. The dreadful complication that occurs with the measles or the pneumonia, and even it can cause the mortality in less than 5 years, that too less than 1 year. So the infantile period, if the child is not vaccinated with the measles, and if you get the measles, the more likely to get the pneumonia as a complication, and even it can lead to fatality. So other complications or the presentation by which the measles can occur as a croup, that is acute laryngotracheobronchitis, tracheitis or bronchiolitis, even acute otitis media. In immunodeficiency child, it can cause even the reactivation of the tuberculosis, sometimes as diarrhea and vomiting, sometimes febrile illness. The fever is so high that even it causes febrile seizures, and vitamin A deficiency in a malnourished child, thereby causing the vitamin A deficiency complications like keratomalacia, bite spot and all, corneal ulceration, and even encephalitis. The encephalitis is a most dreadful complication that occurs 7 to 10 years after the first measles infection. This is because the reactivated of the virus in the immunocompromised. If the person is getting immunocompromised, and if he is not vaccinated, and the virus can reside in the body itself and can get reactivated during that immunocompromised stage, like malignancy or HIV infection or immunomodulator drugs or something. This causes the immunosuppression, thereby causing the reactivation of the virus, and it causes the panencephalitis. The panencephalitis is divided into 4 stages. The first stage usually mild, we will miss this stage. The second stage usually present as a myoclonic, involve the face, and third stage the myoclonus is progressive, that is the viral particles getting infiltrated deeply into the basal ganglia, thereby causing the more involuntary movement in the form of choreoathetosis, hemibellismus like this. And in the fourth stage, the infiltration is so much deeper into the vital structures like which maintain the heart rate, mainly the brainstem region, so thereby causing coma. So the patient usually present with either in the third stage or fourth stage, and the pathology is mainly due to the virus which get reactivated and causes damage to the brainstem and deep inside the brainstem. And another dreadful complication is the black measles, where the hemorrhagic measles, it's also called hemorrhagic measles. The rashes that occurs with the hemorrhagic measles are so red, and sometimes myocarditis can also be caused. And the antenatal mother, if a mother gets the measles infection, there is high chance for the fetal wastage, stillbirths, and 3% may go for congenital malformations if the baby born lively. So such a dreadful disease which can be easily identified only by the clinical manifestation, and it's very well prevented by the vaccination. So the vaccination comes the importance here. The same thing applies to other two, the mumps and rubella also. Mumps, the good thing about the mumps is it has a single host, that is a human, and it has the single genotype. So the infection is easily controllable because the human is the only host. Usually the mumps present as same viral prodromal illness with the parotitis. Either it can be unilateral, but later on progresses to the bilateral parotitis. Here in this slide, you can see the measles rash for this child, which is typical. Since its baby is white, more white in color, the rash appears more. Here it is the Koplik spot opposite to second molar, whitish dot over the red base, usually in the incubation period, that is 4 days before the rash. Here it's our Indian child, where the rash is maculopapular rash, and in Tamil we call it as Manalvari Ammai. And the patient usually told மணலை மேலே தெளிச்ச மாதிரி இருந்துச்சு, மணல்வாரி அம்மை அப்படின்னு சொல்லுவாங்க in the colloquial language. So they themselves diagnosis, but you have to confirm. Here comes the mumps, and it can be easily unilateral parotid swelling or bilateral parotid swelling. In this child, you can even see the nasal discharge on the right side nose with the parotid swelling on the both cheeks, more marked on the left side. So how we can identify the parotid enlargement? See, an imaginary line drawn between the upper border of the ear to the ear lobe. Across the ear lobe, we can see the parotid glands are divided into two equal sides, and if there is a parotid enlargement, it equally enlarges on both sides. And you have to visualize the face from the front side. You can see the lifting of the earlobe. That is the cause for parotid. That is we can diagnose with the parotid enlargement. So parotitis is very important. In Tamil we call the patient will tell us பொண்ணுக்கு வீங்கி அம்மை. For all the fever with rash, in Tamil they will tell us அம்மை. So here it is பொண்ணுக்கு வீங்கி அம்மை. So usually they will not consult or gain importance, because the prodromal illness usually lasts for 3 days and vanishes. The parotid they come with the parotid enlargement stage only. Because of the tenderness in the parotid gland, the child can't able to take feed, so they present as feeding difficulty with the parotid gland enlargement with the prodromal illness. And the reassurance you have to give, usually it subsides with 7 days. Within 7 days the parotid enlargement will subside, and also the prodromal illness. Mumps will cause mainly the meningitis. So all these virus, measles, mumps and rubella, all this can cause the neurological complication. That too, the measles and rubella can cause the neurodegenerative like lesions. That is, after many years of the first infection, they can cause the neurological damage, while the mumps can cause meningitis and sometimes oophorytis and arthritis in male child, oophorytis in female child, and other complications like pancreatitis and all. But comparatively to the other measles, other viral infection like measles and rubella, mumps is not that much dreadful disease, but it can cause meningitis. So the complications of meningitis like sequelae, meningitic sequelae, post-meningitic sequelae, hearing loss, visual blindness, anything can happen. So now we move to the rubella. So in the history, we have to ask for the rubella in antenatal history and all. This is the typical rubella rash. Yes, typical rubella rash. It's also the rash. The characteristic feature of the rubella rash is the day 1 rash, while the measles occurs on the 4th day of the rash. 4th day of the rash is measles, and 1st day rash is a rubella. Usually it occurs in the face, cheeks, upper neck and torso, and it heals in the same pattern but without desquamation, while the measles heals with desquamating skin lesions, but in rubella the lesions heal without desquamation, and it is a day 1 rash. And it also produces a neurodegenerative disorder. that is the progressive rubella panencephalitis PRP, and thrombocytopenia, arthritis. All this can occur with the rubella infection. And the major thing concerned with the rubella is congenital rubella syndrome. In case of measles and mumps, in case of measles, the fetal wastage will be there. In case of mumps, not much wastage. Even the child can. The measles is a very severe infection, thereby causing the fetal wastage. But the mumps, not much fetal wastage. But rubella, fetal wastage plus or minus congenital rubella syndrome. If the child born with the infected mother in the antenatal period, definitely the child will have the congenital rubella syndrome. 1941 ophthalmologist diagnosed this first as a congenital cataract associated with the congenital heart disease. He called it as a congenital rubella syndrome. Later on found to have more the hearing loss, the presentation more of a hearing loss. So the complications more commonly occur. The congenital rubella syndrome is a hearing loss, that too neurological hearing loss, cataract, often congenital blindness, thereby causing congenital blindness, and congenital heart disease, more commonly patent ductus arteriosus and microcephaly. So it's a preventable cause of hearing loss, it's a preventable cause of congenital cataract, it's a preventable cause of microcephaly, and it's a the congenital heart disease, usually the patent ductus arteriosus. The rubella infection in the antenatal mother has produced such a dreadful complication in the newborn. So with this background, this is the typical rubella rash, and this is the congenital cataract. We can diagnose even at birth by looking for the red eye reflex. For the babies at rest after feeding, baby during feeding or after feeding, you have to throw the light by using the pen torch, not by using LED light torch. You can see the red reflex normally. In case of congenital cataract, the red reflex will not be there, and cataract will be seen. And these are the complications that occurs with the congenital cataract, the congenital rubella syndrome among the mothers which are infected with the rubella. So the deafness comes first, and that too ocular complaints, second cataracts and retinopathy, congenital heart disease, mainly the patent ductus arteriosus, right pulmonary artery stenosis, left pulmonary artery stenosis, valvular pulmonic stenosis, low birth weight, psychomotor retardation, neonatal purpura, that is thrombocytopenia, even death due to the viral infection itself. So it's a preventable cause of neonatal events. So with this background, we will move to the MMR vaccine and a short explanation about the diphtheria, pertussis and tetanus. I will share the link about the clinical manifestations and all along with this link about the diphtheria, pertussis and tetanus. All these it's MMR are viral infectious agents. Measles, mumps, rubella, there are so viral vaccines are available, and DPT is a bacterial infections. There the bacterial type of vaccines are available there. So I will share the link about the DPT. The main thing is diphtheria. 4 types are there. Mainly the membranous tonsils is the clinical presentation. The membrane is so tough we can't even wipe out the membrane from the throat, thereby causing bleeding when we try to remove the membrane in the throat. The membrane is so tough it can even occlude the passage of the larynx, thereby causing severe stridor. So the child even may need ventilator support in a case of diphtheria, because if you are going to remove the membrane, or if you are going to try to remove the membrane, it can expose the the toxins are released directly into the bloodstream and thereby causing myocarditis. That is a dreadful complication, another dreadful complication in the diphtheриal infection. And pertussis is so, diphtheria is also prevalent nowadays, and pertussis itself is not prevalent but occurs as a pertussoid. That is, the cough is whooping cough. Its another name is whooping cough. It's also called 100th day cough. The severity and intensity of the cough is such that the child even can go for seizures, hypoxic seizures. The cough, because during the cough the air is flowing inside into the airway passage, and cough is produced. So the air is not eating into the alveoli, thereby causing hypoxia. Even seizures can occur. So it's 100th, it can even prolong up to 100 days. So it's called 100th day cough. And hypoxic fits can also occur with the severe cough, and it also even easily spread among the non-vaccinated children. And tetanus is mainly due to the clostridium tetani infection, and it can produce a neurological manifestation in the form of mainly opisthotonus and malarial clenched jaws and variable clinical presentations, which I share in the link. You just go through that link for the clinical presentation. So with this background, we are going to see the importance of the vaccination. So all these dreadful complications, mainly the neurological and neonatal problems, and sudden the neurodegenerative diseases, and the myocardial death, congenital heart disease, everything are preventable with these vaccines. So the vaccines are mainly introduced to prevent the infectious diseases which are preventable by vaccines, and to prevent the complications. So the vaccination is a procedure of inoculating a product that produces immunological response in the host. So immunization is administering the vaccine and producing the immunity in the host. The immunity what we are going to acquire, it can is either active immunity or passive immunity. Here the active immunity is by natural infection or by the vaccination. The passive immunity is nothing but introduction of the immunoglobulins, thereby neutralizing the circulating toxins. That is passive immunity. For example, in diphtheria, diphthetic serum, and tetanus, anti-tetanus serum, or this passive immunity, where we are going to use the anti-diphthetic serum and anti-tetanus serum are used to neutralize the circulating toxins. So it's a passive immunity. But before that, we are producing the immunological response by giving the DPT vaccine. So the DPT vaccine, this is the types of immunity. And one more immunity is herd immunity. It's nothing but if we are getting immunized more than 80% of the population in a community, then that will produce a herd immunity. This mainly occurs as an example in the polio, where you can, and even in measles and rubella, that is live vaccines can produce the herd immunity, because the live vaccines are nothing but the virulent organisms or the viral particles that can produce the immunity but not the infection. So the live attenuated vaccines like MMR and oral polio can produce the herd immunity. Mostly the live vaccines has good efficacy but poor safety profile, because they are virulent particles with the immunogenicity but not with the infectivity. That is, they produce immunological response with the less virulence, with the without infection. So they have to be used carefully in a immunocompromised host or in the state, because already the immunological system is weak, and when we are giving the live vaccines, thereby it can make us infection in that host. So the vaccines can be classified into 4 types: live attenuated, killed and inactivated vaccines, subunit or conjugate vaccines, recombinant vaccine, and toxoid. 5 types are there. The killed inactivated vaccines. The killed inactivated vaccines are nothing but the antigenicity is maintained. But the virulence component is getting inactivated. Here you are abolishing the virulent. The antigen is being killed. It's a viral particle where the virulence is killed, but the antigenicity is maintained. It's simply called killed antigen. Example, bacterial, you can classify it's a bacterial killed vaccines or inactivated vaccines, viral killed vaccines. So bacterial killed vaccines, example is hepatitis A, typhoid, cholera. Viral killed vaccines, say IPV, injectable polio vaccine, hepatitis B, rabies, influenza vaccine, JE vaccine. These killed inactivated vaccines have good safety but poor good safety and good safety and efficacy. But live vaccines are nothing but the virulence is reduced to produce the immunity by growing repeatedly in a culture medium, most probably chick embryo like this. So the virulence is kept at the minimum, but immunogenicity is maintained. So it has the good efficacy, but safety is doubtful in case of immunocompromised host. It can be divided into bacterial live vaccines, that is BCG, typhi oral, and viral live vaccines, oral polio vaccines, measles, mumps, rubella, yellow fever as an example. And the subunit or the conjugate vaccines are nothing but the purified antigen. These are conjugate vaccines in the name. They can be combined with any bacterial vaccines so that the potency of the other vaccine which are supplied along with this is improved. The subunit or conjugate example is Hib and hepatitis B. It can be combined, and even pneumococcal vaccine, it can be combined with the DPT, so thereby increasing the potency of the DPT vaccine also. The recombinant vaccine example is the hepatitis B, which is available as a recombinant vaccine. And toxoids, the two toxoids which are available are nothing but the diphtheria and tetanus. So the toxoids are nothing but the inactivated toxins. These are toxoids are nothing but bacterial, so inactivated toxins. So this is how the vaccines can be are being classified. Our vaccine comes, the DPT vaccine comes under killed inactivated vaccine. DPT comes under two toxoid with the killed inactivated vaccine, and MMR comes under live attenuated vaccine. So the two words about the expanded program of immunization and universal immunization program. The first programs to start for the immunization among the Indian children is the expanded program of immunization. It covers the major 6 diseases, vaccine preventable diseases, the tuberculosis by BCG, DPT for preventing diphtheria, pertussis and tetanus, and measles vaccine, and OPV to prevent the polio. This is further improved to include the other vaccines like hepatitis B, Hib, TT and JE vaccine for preventing the hepatitis B, which has a major role in production of hepatitis B cell carcinoma. If the child gets hepatitis B in the younger age, the child when it grows even to the adolescent age, it can go for hepatocellular carcinoma. A Hib vaccine, that is one of the common cause for meningitis in the toddlers age group and even the hearing loss, and JE and tetanus toxoid. So this comes under the universal program on immunization. So the basic difference between the expanded program of immunization and the universal program of immunization is the inclusion of the hepatitis B and Hib, TT and JE vaccines along with the 6 vaccine preventable diseases, that are BCG, DPT, OPV and measles. So how the vaccines are being maintained, the cold chain. Few lines about the cold chain. So the cold chain has to be maintained for the good efficacy and good safety profile for the vaccine. It's nothing but maintaining the recommended temperature for that vaccine from the site of manufacturer to the site of administration. For this, an orderly applied cold chain from the DD office, that is Deputy Director of Health. There they will have the walk-in room cold chain walk-in cold room that can supply, that is the regional level room storage of vaccine that supply 4 to 5 districts. From there, the vaccines are supplied to all the districts through the ILR, that is ice-lined refrigerator. ILR is nothing but ice-lined refrigerator. In walk-in cold room, they will have the whole room is cold, maintained in a warm cold chain, and the deep freezer and the ILR. So ILR has a capacity of 300 or 240 liters, and the deep freezer has a capacity of 300 liters. It is available in all the districts. The vaccine supplied from the regional level to the district by means of deep freezer or ILR. From the deep freezer and ILR, it's supplied through a small deep freezer which has a capacity of 140 liters, that is in the PHC. From the small deep freezer, the vaccines are supplied through the cold boxes to the periphery center, that is HSC, Health Sub Center and all. From there, it can be taken through the vaccine carriers carrying 60 to 20 vials, and from there to the day carriers in the form of 6 to 8 vials. So this is how the cold chain is maintained during the transport of the vaccines. So what is the reverse cold chain? It is nothing but in the AFE surveillance, the stool samples are maintained in the same temperature until it reaches the laboratory for detecting the polio virus. This is reverse cold chain. How the vaccines are kept in the ILR, ice-lined refrigerator. The freezer component, we can store the only polio vaccines. In the uppermost compartment, BCG and measles. That is, freezer compartment is meant for live vaccines, mainly the polio. Even MMR can be kept, but the temperature is far below, less than 2 degrees Celsius. So mainly the oral polio is being kept there. And uppermost compartment, mainly the BCG and measles. And the second compartment, they will store the DPT, DT, TT and hepatitis B. The lowermost compartment, diluents, the normal saline and distilled water. So this is how the vaccine storage in the ice-lined refrigerator, that is ILR and the deep freezer, is kept. And what is warm chain? This warm chain is not related with vaccines. Warm chain is in the newborn care to make the baby warm and to prevent the hypothermia in the newborn. So warm chain not occurs with vaccines, not in the context of vaccines. The newborn care only warm chain is maintained. Few lines about that. So warm delivery room, warm resuscitation station, dry the baby immediately after delivery, and keep the baby with skin to skin contact with the mother, and breastfeed the baby, and no baby bath immediately after birth, and appropriate clothing and bedding, even covering the scalp, and appropriate rooming in. The baby should kept in the mother side only. And warm transportation, when the baby is transported from the hospital to the home, warm transport, the weakest link in maintaining the warm chain in the newborn care to prevent the hypothermia, and training of the healthcare providers to know about this. This is the warm chain. It is main thing is the warm chain is not linked with the vaccine. It's not at all linked with the vaccines. It is in the newborn care. As I told, 10 points to be remembered. So now we can see that route of administration for the DPT vaccine and MMR. Killed vaccines, all the vaccines are administered through intramuscular. Most of the vaccines. Intradermal, only one vaccine, that is BCG. The dosage is 0.1 ml. And subcutaneous, the live vaccines are administered. Injectable live vaccines are administered by the subcutaneous route. Oral polio is an live vaccine but administered through oral cavity, and rotaviral is also live vaccine that is administered through the oral cavity. So the injectable live vaccine, mainly the MMR, is injected as in the subcutaneous route, in the older children, upper deltoid, or in the anterior aspect of the thigh, lateral aspect of the thigh. So this is the dosage is 0.5 ml. All the vaccines dosage are 0.5 ml except BCG, which is 0.1 ml. The only intradermal route for BCG and other DPT and all bacterial vaccines mainly intramuscular, live vaccines mainly subcutaneous. This is a simple way. 0.5 ml is the dosage for both the DPT and MMR. The thing is, what we in government the DPT is combined with the Hib and hepatitis B, so it comes as pentavalent vaccine, that is DPT plus Hib plus hepatitis B. It is applied in the dosage schedule of year 6th, 10th and 14th week as a primary schedule, that is before the 6 months, because these are the vaccines doesn't produce immunity at birth. There is no maternal antibody that can be transmitted from the mother to the baby to prevent the infection in these first 6 months. So the DPT vaccine is being administered within 6 months, the primary schedule, and a booster dose at 18 months, 12 to 18 months, and for a second booster dose at the 4th to 5th month. Now the DPT is being replaced as DT because the pertussis is not significant beyond the age of 3 years. The single booster is enough to produce the immunity for the pertussis. Beyond 3 years, less likely to the child to have the pertussis infection, so it is replaced by the DT. And also the side effect, the adverse events following the immunization is mainly due to the pertussis component in the DPT. So what are the complications that occurs with the vaccination of the DPT vaccines? The high grade fever, unconsolable cry, that is more than 3 hours the baby cries and it cannot be consoled, and there will not be any other etiology for crying. So the unconsolable or inconsolable cry, that is more than 3 hours with other things being normal, and hypotonic hyporesponsive episode and convulsions and even acute encephalopathy. So these are the dreadful complications that occurs with the DPT, and that too due to the pertussis component. So only the beyond 3 years the vaccine pertussis is not advised. Only DT is advised at the age of 5 years. That too after 7 years. After 7 years, the diphtheria component, the diphtheritic component of the DT is replaced as D, that is low dose diphtheritic component is included as a toxide along with the tetanus. This is because the diphtheritic infection, as the age progresses, it produces good reactogenicity, weak immunogenicity. So instead of good reactogenicity is essential for the booster doses. So only the capital D is replaced into small d, that available as Tdap, T small d small ap, that is acellular pertussis. So in private it's being given as acellular pertussis as for the booster doses, that should be continued even beyond 7 years. In government it given as a DPT, but at the 5th year DT is given, and after 7 years TD, that is capital T and small d, at the age of 10 years and at the age of 12 years. This is applied even to the pregnant mothers, because by administering this we are immunizing the newborn within the utero itself. This is about the DPT vaccine. So the febrile convulsion is not a contraindication for the DPT vaccine. Progressive neurological disorder, the DPT should not be given. So febrile or CP child are not the contraindication for the DPT vaccine. Sometimes swollen limb of the injected site can also be a acute self-limiting complication, that is a major complication after fever. So this is about the DPT vaccine. And about the MMR vaccine, as I already told, subcutaneous route 0.5 ml at the age of 10 months, and at the age of 18 months, one more booster dose can be given, because the live vaccines 2 doses is enough to produce the immunogenicity more than 90%. So the measles strain, the strain is used in the measles vaccine is Edmonton Zagreb strain. It's a child name, but the first immunized is the measles. So Edmonton Zagreb strain. In mumps, Gerald Lynn strain, and rubella Vistar RA27/3. These are all the genotypes or the persons who identify the vaccine. So and this one is the first child which is immunized. So measles, mumps, rubella, the vaccine is administered in the 0.5 ml subcutaneous route over the right deltoid, and the diluent which is used with the MMR is the distilled water. So the vaccine mixed with the diluent should be used within 6 hours, because the dreadful complication with the vaccination in the MMR is the Staphylococcus scalded syndrome if the vaccine vial is infected. The importance of the rubella, as already told, the MMR vaccine or the MR vaccine is the prevention of the congenital rubella syndrome. But after the rubella vaccine, pregnancy should be delayed, and the risk of rubella infection in the neonate should be explained to the mother. And this is about the MMR vaccine. The immunosuppression in pregnancy is a contraindication, and the rubella is also one of the pubertal vaccine. The other pubertal vaccines are the papilloma viral vaccine, Cervarix. So the human papilloma viral vaccines, Cervarix, comes under the adolescent age vaccines. So this is about the measles, mumps, rubella vaccines. Okay, so I will tell in short about the AEFI. What is AEFI? It is nothing but the adverse events following the immunization. So the adverse events following immunization can be classified as very common, uncommon, and rare. Very common and common are nothing but 1 to 10%. So very common is more than 10%. The fever is the most common adverse event following immunization that occur with any vaccine. In measles, the fever can occur even 14 days after the immunization, but DPT and all even the next day or at the night of the vaccine day itself can occur. So very common AEFI is an fever, and frequent, that is 1 to 10% of the immunized child can give the malaise or easy fatigability and like this tiredness and all due to the fever, but these dreadful complications can settle on their own. And uncommon and rare complications are nothing but this inconsolable cry, hypotonic hyporesponsive episode in the DPT, and severe allergic reaction due to the diluent which is used, that is Staphylococcus scalded syndrome, as I already told. So these are the adverse events following immunization. So the vaccine AEFIs are classified as vaccine product related reaction, vaccine quality defect related reaction, immunization error related reaction, immunization anxiety related reaction, and coincidental event. Coincidental event is nothing but the vaccine coincidental event is nothing but from the back we are from reverse we can see coincidental event should be reported. The vaccination procedure and the event that occurs has no coincidental event. For example, diarrhea and vomiting can occur with any child. Mainly loose stools can occur with any child, but it is not related to any kind of vaccine. The GAT symptoms are not at all related to the vaccination, so it's a coincidental event. And there the anxiety related events are nothing but vasovagal syncope. or hypotonic hyporesponsive episode. This is due to the anxiety in the children before the vaccination. So proper counseling about these events should be. Any injection can cause and any vaccine can cause this. So consent should be explained, consent and importance of the observation after vaccination should be explained to the attenders after when they come for immunization. So it's anxiety related, and inappropriate vaccine handling, prescription or administration can cause the immunization error related reaction. This is highly preventable. So the preventable adverse event is this inappropriate vaccine handling, prescription and administration. As I already told, example is measles. If diluent, if the reconstituted measles vaccine is not used within 6 hours, definitely the child will get Staphylococcus aureus syndrome. If it's going to be contaminated, then it mainly in the multiviral dose. So it's a preventable. If it is reconstituted and if it is used immediately, there is no chance for the infection, this Staphylococcus aureus syndrome like event. So it's a vaccine inappropriate related, and the vaccine quality related. Defective inactivation of the polio virus in IPV sometimes can cause the vaccine related polio infection. That is, the inactivation of the live vaccine, if it is not properly done, then itself can cause viral illness, polio like viral illness. So it's very rare to see this, but still it's one of the AEFI. Then that batch should be intimated to the DD office for further stopping the administration. The vaccine product related event following immunization is due to the inherent property of the vaccine. For example, and this is also most common, the fever or the swelling or the redness, these are vaccine product related reaction, and this occurs with every vaccine and it is self-limiting. So main thing is the patient should be counseled about the importance of the vaccination rather than acquiring the infection. As I already told, all these viral illness can cause major sequelae in the newborn mother and neonatal complications and neurological neurodegenerative diseases and overall major dreadful complications. So this should be explained to the attenders or the parents who are hesitant to get the vaccine, so that we can improve the coverage. And this is a slide. For example, in the measles, if the child is going to get the measles infection, the complication of the complication they are going to get as a otitis media 9%, pneumonia 6%, diarrhea 6%, post infectious encephalitis 0.5, SSPE 1 in 1 lakh, but dreadful and fatal complication, that is SSPE, but none in the measles vaccine. So the vaccination importance should be explained to the parents who are coming for vaccines. So to ensure continued public acceptance of the vaccines, it is essential to monitor the incidence of the AEFI. So the AEFI should be yearly reported. Even minor illness should be counseled to the parents, and consent should be explained. Scientifically evaluate the likely association, respond to the newly identified risk from the vaccines, and communicate the benefits and the risk to the patients and parents through a trusted healthcare source in advance of the vaccinations time. So this is about the DPT MMR vaccine is being usually kept as a spotter and a short notes. Here this is the supply, government supply, and you can see even the vaccine VVM monitor in the measles. So all these vaccine DPT MMR in government we are giving only MR, because mumps is not that much dreadful disease to produce high infectivity, mainly spread. So measles and rubella is major. So MR vaccine and DPT we are giving, as I already told in the dosage schedule, and every vial has been provided with the VVM, just like polio, to monitor um, monitor the efficacy. If this is VVM, you can see a central square with a dim color and a dark color circle around it. If the light color square matches that outside color, then the vaccine is not suitable for immunization, and it should be discarded. This is how we can monitor the efficacy and the vaccine. So thank you, students. I will share the DPT link with this also. You go through that, and please read the SPM book, Park, for further information. Thank you.